I'm the only CLL talk, so I thought I'd also touch on relapse disease, all in 20 minutes. So let's see what we can do. Disclosures. CLL is the most common leukemia in the Western world. About 19,000 new cases and 4,600 deaths in 2006. As you know, workup, I won't belabor that with you. You know how to do that. Fish studies, but now more and more important it is more important to get Ig heavy chain gene rearrangement status, because mutated versus unmutated disease has very different prognoses. Diagnostic criteria, just to remind people, 5,000 lymphocytes per microliter. Otherwise, it's a MBL, monoclonal B-cell lymphocytosis. The old RIDE staging system, which was developed with a CBC and a physical exam, as you know, still separates people out significantly by survival. And here's survival by FISH. As you know, 17p deletion portends a very poor prognosis. 11q deletion is worse than average. Trisomy 12 and normal tend to be fairly similar. We can separate out trisomy 12 based on Notch 1 status, but we can talk about that separately. Notch 1 positive trisomy 12 tends to have a higher risk of transformation, and a worse prognosis for that reason. 13q deletion. If there's 13q and a second abnormality, it's always the worst one that takes precedence. It tends to outgrow the good one. So the yellow line is survival with 13q only. Ig heavy chain gene rearrangement status is something still I can't get a lot of oncologists to do in the United States. But as you can see, the survival is significantly different with patients that are mutated versus unmutated, with mutated being a better prognosis. And that's true across all stages, just looking at Binet stage A as an example. Historical treatment, as you know, alkylating agents back in the 80s, purine analogs with combinations such as FCR into the 90s. And that it still can play a role. Purine analogs plus or minus newer agents, and then small molecules have taken over the past 5 years. So targeting of BCR signaling in CLL, this is what we use to base our targeted agents. As you know, ibrutinib targets BTK, and that was the first targeted agent on the market. We'll talk a lot about that drug. And then the PI3 kinase inhibitors, idelalisib and now duvelisib, has been approved by the FDA in the United States. So we'll talk about those. We'll also talk about venetoclax, which is a BCL2 inhibitor. As you know, BCL2 overexpression blocks cell death. So by binding and blocking BCL2 overexpression, it leads to apoptosis, which is supposed to occur. And this works very effectively in CLL. CLL cells seem to be BCL2 dependent more so than other lymphomas, particularly follicular lymphoma. Why doesn't venetoclax work in follicular lymphoma? I think it's because it has other escape mechanisms through BCLX and other anti-apoptotic pathways. First line treatment. So this is CLL8, which was FCR chemotherapy. Just showing an example that with the best curve there are patients who are Ig heavy chain mutated patients, and they can have very long-term survival with FCR, even though we're slowly abandoning chemotherapy. For patients, particularly 13q deleted, Ig heavy chain mutated patients can have very long survival with FCR chemotherapy. So as far as upfront therapy, Resonate-2 was done after Resonate-1, since that was done in the relapse setting first, but upfront, ibrutinib was compared with chlorambucil in untreated patients. And the significant difference here, you can see on the left are patients who are unmutated, having a much better prognosis with ibrutinib than with chlorambucil, much improved progression-free survival. And with the mutated group, it's not quite as separate of curves. because mutated patients do better with chemotherapy in general. But the curve would probably be more significant since a lot of the chlamydia patients crossed over to ibrutinib eventually. So ibrutinib was superior with both mutated and unmutated groups. This was just looking at chemotherapy, bendamustine Rituxan versus ibrutinib, and versus ibrutinib plus Rituxan. This was in older patients who were not FCR eligible. So in this population, you can see the red and the blue curves are patients who received either ibrutinib or ibrutinib plus Rituxan. The overall group on the left, mutated group on the right. So a couple things to learn from this. One is that adding Rituxan to ibrutinib didn't seem to do anything. That the ibrutinib and Rituxan group did just as well as ibrutinib. So you can save the money and save the Rituxan, ibrutinib alone. In the mutated group, you can see the difference is not as big. Again, patients that got BR probably eventually got ibrutinib, and that cut down on the survival difference. But again, I think that it shows that it's superior for both mutated and unmutated groups. Now, of course, if you've got someone with CLL and their expected survival from comorbidities is 3 years and they've gotten 11q, you might get 11q out of BR. You know, it's still reasonable to think about chemotherapy depending on the patient. So this is the intention to treat, which is all fairly similar, again, because of the crossover in the bendamustine group to receiving ibrutinib. So that was ibrutinib versus BR. What about ibrutinib versus FCR? So this was ibrutinib plus Rituxan. This was prior to the previous trial that showed the Rituxan didn't really add much. So ibrutinib plus Rituxan versus FCR. Again, all comers, ibrutinib better than FCR, particularly in the unmutated group. Not as big a difference in the mutated group, particularly if you take out the 17Ps and 11Qs. Again, FCR is still a very viable treatment option. This is overall survival curves. So more recently, as far as upfront therapy goes, venetoclax was looked at plus obinutuzumab for patients in previously untreated CLL. So this is progression-free survival with a significant difference, showing an advantage of venetoclax obinutuzumab over chlorambucil plus obinutuzumab. So this was held up across both mutated and unmutated groups. The important thing to consider is in this trial, this was time-limited therapy. So when you're looking at treating someone with ibrutinib, theoretically that's the rest of their life. It's an expensive drug, could be a lot of years, could be very expensive. Obinutuzumab in this trial was just for a year. Certainly patients, this shows again the difference between chemotherapy versus targeted therapy, and the mutated group doing a whole lot worse. Thought I had a slide, but with sort of but with relatively short follow-up, we've seen that patients can remain in remission off of venetoclax. We will go over the Murano data where we looked at Rituxan plus venetoclax in the relapsed setting, have a little bit longer follow-up with that. We'll look at what kind of drop-off you have by stopping the venetoclax. The question is, if venetoclax is going to be a lot cheaper because it's time-limited, do the patients stay in remission, or they all start to relapse, you have to put them back on venetoclax, and you end up in the same financial situation. So in the relapsed refractory setting, you can get some very long remissions with combination chemotherapy. And if they had a long remission the first time, usually associated with good prognostic factors, you can use chemotherapy again. Usually we'll recheck FISH status, because as you know, FISH can change. You can acquire deletion 17p or a TP53 mutation. You can acquire 11q. Your mutational status stays the same. So when I restart chemotherapy, I relook to see if they have a 17p, where chemotherapy is just not going to be helpful. There's additional data now looking at using a kinase inhibitor, ibrutinib, plus chemotherapy or idelalisib plus chemotherapy. So combinations are being looked at. In the States, most patients, after getting one course of chemotherapy, usually it's a targeted agent that they get thereafter. As far as which novel agent, so novel agents just referring to the targeted agents. Ibrutinib is the one that's most commonly used currently in the States. The reason for that is that we have longer follow-up. We have about 7-year follow-up now showing that patients at least have disease control with ibrutinib. Very few, if any, patients have complete eradication of disease. If you look by scanning bone marrow biopsy, look by minimal residual disease by 4-color flow, majority of patients will still have evidence of disease while on ibrutinib. So that means they stay on it indefinitely. But we have longer follow-up. The ibrutinib data, I'll show you the relapse data in the Murano trial. It's the longest we've got with venetoclax. And the question is whether that's going to hold up over time. And that may become a change if time-limited therapy can do the job. It'll be financially cheaper, even though neither drug is cheap. But 2 years of a drug is cheaper than 10, 15, who knows what. The thing that does limit the use of ibrutinib, as you know, increased risk of atrial fibrillation. It's about 10% in patients with taking ibrutinib. That can be somewhat predictive. Patients with prior cardiac disease, patients with prior dysrhythmias, patients with long-standing hypertension, and certainly older patients are all at higher risk of cardiac complications from ibrutinib. So in that case, you may want to consider either venetoclax or a PI3 kinase inhibitor. And just to review, for the PI3 kinase inhibitors, idelalisib has been approved for CLL in the United States with Rituxan, and duvelisib has been approved by itself. We have much longer follow-up with idelalisib than we do with duvelisib, but duvelisib, in my experience, has quite a bit fewer side effects than idelalisib. And just to review idelalisib, as you know, it tends to create autoimmune-based side effects, autoimmune hepatitis, autoimmune pneumonitis, autoimmune colitis. These are the most common things with idelalisib. And these seem to be much less common with duvelisib. I've used it a fair amount for CLL, and we're also been using it extensively in T-cell lymphomas. So that does seem to be better tolerated if you can get your hands on it. So ibrutinib is usually, as I said, the most commonly used novel agent. What's the second-line agent? And you have options of venetoclax with or without rituximab, idelalisib, duvelisib. If it wasn't the first novel agent, then you go back to ibrutinib. And just to review, I'll review the data of venetoclax plus Rituxan, the Murano data, which is data of venetoclax in relapsed disease. Keep in mind, venetoclax plus obinutuzumab is what was studied in the first-line setting. And then in the relapsed disease, it was venetoclax plus Rituxan. I'm not sure if it matters, but that's what was studied in those two settings. The other thing to keep in mind is it's never been studied plus or minus a monoclonal antibody. And we did that with ibrutinib. Remember, we did ibrutinib plus or minus Rituxan, no difference. We haven't done that with venetoclax. Whether you need rituximab or obinutuzumab, I don't know. But at least for now, what's been at least approved in the United States is venetoclax obinutuzumab for initial therapy and venetoclax plus Rituxan for relapsed disease. So this was just ibrutinib in relapsed disease, early phase trial, just showing a high overall response rate, very low CR rate, because again, we don't get CRs, we just get disease control with ibrutinib. But very good progression-free survival and overall survival. And this was the first agent to really have effect in people who were chemotherapy refractory. Again, this is progression-free survival, overall survival, looking at mutated versus unmutated, and shows that mutational status does not matter with the targeted agents, as it does. It's critical in chemotherapy, but not so in the targeted agents. The survival curves are the same. So this is looking at various fish groups. So as you know, 17p is bad in chemotherapy. It's also bad in ibrutinib. It's better than chemotherapy, but the median progression-free survival for ibrutinib in 17p deleted patients is about 25, 26 months. So a little over 2 years. There are patients that can do better, there are patients that do worse, but it's around 2 years. And so for someone that is chemotherapy refractory prior to ibrutinib, the median survival for 17p deleted patients was less than 6 months. So 25 months, okay, you bought some good time. Of course, you can go from there on to another targeted agent such as venetoclax. And this also shows that 11qs do a little worse, though the mutational status doesn't seem to matter. Okay, so this was the trial. Ibrutinib looked promising in phase 1 trial. So comparative trial, phase 3, ibrutinib versus, all right, let's say you make ibrutinib. What drug are you going to run it up against? Probably the weakest drug you can think of, and that's ofatumumab. It's actually approved for CLL in the United States, but it's not exactly the most potent drug. But anyway, that's what they compared it to. Standard ibrutinib versus ofatumumab. This was the RESONATE trial, and you can see a very significant difference in progression-free survival, and even the overall survival is different, even though the ofatumumab patients crossed over to ibrutinib afterwards. So this was the first trial that really compared it to another agent in the relapse setting and put ibrutinib on the map. Just a quick reminder that ibrutinib's been added to chemotherapy. This is the Helios trial looking at ibrutinib plus bendamustine rituximab versus bendamustine rituximab alone, and significant differences in progression-free survival and even overall survival. Whether you need the combination or whether these patients would have done well with ibrutinib alone, not so sure, but at least tells you you can use combination kinase and chemotherapy regimens. So what do we do for patients that fail ibrutinib? There are certain mechanisms of failure for ibrutinib, for sure. And so you have options for second-line therapy. Most commonly in the United States now, it's going to be venetoclax. Certainly the PI3 kinase inhibitors are still available. And we do see that some patients can respond to idelalisib or duvelisib even after progressing on ibrutinib. But it looks as though venetoclax is probably the better agent. And we'll look at that in the Murano trial. So this was ibrutinib versus bendamustine plus rituximab. This was in relapsed patients. Sorry, this is venetoclax plus rituximab versus BR in patients who are refractory to ibrutinib. So here are the curves, BR versus venetoclax and rituximab in the ibrutinib-resistant patient. You can see a significant difference, improvement in the venetoclax arm. Again, this was done with rituximab. Whether you need the rituximab, I'm not sure. Whether obinutuzumab is better than rituximab, I don't know. But at least it shows that venetoclax is better than chemotherapy in the BTK-resistant subgroup. So there is a survival difference also. And then this is what we have for data when patients came off of venetoclax. So in the relapse setting in this trial, venetoclax is for 2 years. Upfront setting it was 1 year. I guess the rationale was if you have a resistant disease, you need it longer. I don't know. But this is the curve showing that there are some patients that are relapsing as their venetoclax is stopped, but a significant proportion of patients that are not. I think we need longer follow-up of this to really learn about whether time-limited therapy is going to be effective. Certainly, you can look at their disease state at the 2-year mark, both by scan, bone marrow biopsy, histology, and also by minimal residual disease based on 4-pellet flow. So what we really need to learn is if you're MRD negative, is your curve going to be a whole lot better? And those are the patients that can stay off of venetoclax. Or if someone's MRD positive, do we put them back on venetoclax? And we don't have the answer to that quite yet, but I think we will soon. So CLL is a very heterogeneous disease. We didn't appreciate this not that long ago. We first started to learn about 17p deletion. I'd have patients referred into me that were refractory to 5 straight chemotherapy regimens. And I'd say, you have 17p deletion. I just know you do. And you do the cytogenetics, and they do. And that's something that we didn't know about not all that long ago. But now it's guiding our therapy based on FISH, and also mutational status is a very important step in that. We still watch and wait initially because we don't think that, or at least we don't know that any of these targeted therapies are curative. The role for chemoimmunotherapy, at least in the States, is diminishing. Novel agents are increasing in number. Acalabrutinib, a second-line BTK inhibitor, should be approved for CLL in the United States probably within 6 months. It's already approved for mantle cell lymphoma. There's 2 PI3 kinases, as we talked about, idelalisib and duvelisib, and then there's venetoclax. And the question is not just the sequencing of these drugs, but whether we can use these drugs together. There have been a number of trials looking at either ibrutinib or acalabrutinib plus venetoclax with or without antibody, and trying to see if we get, do we get better minimal residual disease negativity by using combination, and maybe if you add in maybe 2 years of ibrutinib plus venetoclax, it's going to be cheaper than endless ibrutinib. So these are questions we have to answer, and we have current ongoing trials to try to answer these questions. I think that's